You're listening to the Cancer Assist podcast, hosted by Dr. Bill Evans and brought to you by the Cancer Assistance Program. Wherever you are in your experience, we're here to provide help and hope as you navigate cancer prevention, treatment, and care. Help when you really need it.
Well, welcome to the Cancer Assist Show. I'm your host, Dr. Bill Evans, Professor Emeritus in the Department of Oncology at McMaster University, and formerly president of the Juravinski Hospital and Cancer Centre. I mentioned that we're in Hamilton, partly because I know we have a lot of international listeners around the globe, and welcome to you. We particularly do these podcasts for residents in the Hamilton area who are supported by the Cancer Assistance Program, which provides a variety of free services. We're going to be talking about something very interesting today that I think has kind of been overlooked in a way. It's the discussions that doctors should have with their patients around their serious illness. And this is a topic that hasn't had a lot of research, but it's starting to gain prominence. And I have a guest with me who I'll introduce more fully in a moment, Dr. Oren Levine, who is working in this area and bringing this kind of research and education to the physicians and caregivers at the Juravinski Cancer Centre. But just before we start, I'm so pleased to be doing this podcast on behalf of the Cancer Assistance Program because of the variety of free services that are provided to patients in our region. And those include free rides to and from medical appointments, availability of free loans of equipment that keep patients safe in their homes, ranging from canes to ambulators and wheelchairs, commode chairs, all sorts of assistance, and as well head coverings for those who lose hair during treatment, nutritional supports, urinary incontinence supplies, just a range of things that help people get through the cancer journey a little easier. And of course, part of getting through the journey is having good conversations with your oncologist, and that's really the focus of this particular conversation. And Dr. Oren Levine is going to lead us through that and tell us what's happening in way of research and educational initiatives in that area. Now, Oren is a medical oncologist, and he's an associate professor in the Department of Oncology at McMaster University, and he's also a full-time member of the Escarpment Cancer Research Institute. And Oren, it's great to have you here, and welcome to the program.
Thank you so much. Great to be here.
Now, I'm always interested to know how people ended up in the particular area that they're working in, how you became a medical oncologist. I know that you have a relative. Your dad's a very prominent oncologist in this community and indeed across Canada. And that may have been a bit of an influence, but how did you choose medical oncology as a profession?
Oh, thanks for asking. And I guess you know the backstory a little bit, but maybe for the reason that you mentioned, that there's a bit of a family connection. I actually tried to avoid medical oncology.
You didn't succeed very well.
Didn't succeed, no. But after medical school, I did my residency in internal medicine, which requires going through different rotations. And I actually had a different direction in mind. I thought I'd go into rheumatology, but it was in the process of doing the different rotations and different specialties. And of course, a rotation in my second year of internal medicine in medical oncology, where I just felt it was the best fit for me unexpectedly. It caught me off guard. And I think really what resonated with me was the type of communication that happens in the oncology clinic. Somehow felt a little bit different than other fields of medicine. And I saw mentors having these really, really meaningful person-centered conversations, connecting at a very personal level with the people that they're taking care of.
So that's interesting. It was both the interest in medical oncology, but it was the interest in the communication you saw from mentors that drew you both into the field of oncology, but also to your focus of research and education.
Yeah, that's right.
Now, I think a lot of patients and people supporting patients would think that these conversations are taking place all the time in a routine, but I think the truth is different than that in fact, there's a lot of room for improvement. There are conversations about end of life and resuscitation, but the kind of communication that you're focusing on, these sort of serious illness conversations, is much more than that, I think. Can you describe what's really entailed in a serious illness conversation and the kind of program you're leading to?
For sure, yeah. And maybe I'll try to distinguish some terms, serious illness communication versus what is a serious illness conversation. And maybe I'll even take one step back and what is a serious illness?
Yes.
Let's start there.
Or define that.
So a serious illness, we think of any illness that has a threat of ending someone's life in the next year. An illness that has a very significant impact on quality of life and someone's ability to function in their regular life roles. And finally, an illness that is considered to be a major burden to the individual who's sick and to their family members. There are many different illnesses that meet these criteria, but often advanced cancer is considered a serious illness. In caring for people with advanced cancer or other serious illnesses, really all communication, in a way, is serious illness communication. And that can be over the course of that illness, having conversations where we're focusing on helping someone understand their health, if they wish, or to the degree that they wish, understanding what to expect in the future or prognosis, getting to know what's important to that patient, their values, their goals, their fears, sources of strength, and so on. And in the process, building a connection, building trust, building rapport between the individual who's sick and their healthcare team. So all of that is serious illness communication. And I think of that as preparing for decision making. And then sometimes along the way, there are decisions that have to be made. What sort of treatment are we going to use to address the illness? And someone who's more critically ill, what are their resuscitation wishes? You mentioned deciding about resuscitation wishes. That is an important decision. But to make those decisions most effectively, it should be based on serious illness communication that's happened over time.
And I think when you were defining a serious illness, often it's in the context of what people call the surprise question. Yeah. Would you be surprised if your patient passed away in the coming year? And if the answer is no, then that's a serious illness. And the kinds of conversations that have more depth to them, not just about the treatment, but understanding the patient's preferences for care, understanding their family, who's at home, are there dependent children, are they a single parent, all sorts of things. It really requires that kind of more fulsome kind of conversation to understand what the patient might like having a serious illness and perhaps dying with a year's time. So I think from my perspective as an old oncologist, I saw a lot of what I call sort of perfunctory communication to patients early in my career, where patients were just often bluntly told that you have a cancer, I'm going to do this procedure, and if it's a cancer, you're going to have this other treatment, and that was the end of the discussion, without any attempt to form a relationship with the patient as a human and understand where they were coming from, what their preferences are for treatment. So I think that's one of the distinct differences, and I guess you saw some of that in your training, and that was attractive to you to have that kind of experience with other human beings who are going through a very difficult time.
Right, yeah. No, I think I found it rewarding, validating to be able to help someone at a very vulnerable time, someone in distress, and the way that I choose to communicate can actually help address that distress just through the style of communication.
But it doesn't routinely happen, and so there are a number of barriers that get in the way of having these kinds of conversations, and maybe you could talk a little bit about why it's not sort of routine that doctors have these serious illness conversations.
Sure. I think there's a number of reasons that it doesn't happen perhaps as often as we'd like or in as much depth and detail as we'd like. One is limited time. The healthcare teams are very busy and the clinics are overbooked, and it's perceived that these will be conversations that take a long time. That can be the case, but I think an average conversation when following a structured approach will take around 20 minutes. And I think that's time really, really well spent, time that helps foster that trust, shared understanding, so that over the course of that illness, as high-stakes decisions have to be made, there's already an important connection to support the decisions. So time spent up front early on saves time later on.
Yeah.
But time remains a challenge. I think there's also a perception that talking about illness or rather preparing for end of life in the context of a serious illness, that might take away hope, or that might damage the relationship between a healthcare team, particularly a physician, and the individual who's sick. Again, that is I believe, a misperception. By having these conversations, which we shouldn't confuse with bad news conversations. This is not about forcing negative information. This is about making space to learn what's most important to an individual, what they want from their healthcare, meeting their information needs, trying to answer the questions that remain unanswered that cause that person worry and distress for the unknown. By taking the time to do this, typically people feel more connected, more trust with their healthcare team. So again, it's a constructive process. I think the last thing I'll mention in terms of barriers to this process, this does feel uncomfortable sometimes for the healthcare team members. It causes anxiety among the healthcare professionals, doctors included. And yet, when we look at this scientifically, and I think we'll talk about the evidence, we find time and again that by taking an organized approach to having these conversations, even following a structured conversation guide, the clinicians or the healthcare providers find they're less anxious and they get more satisfaction out of their professional roles.
And I guess they feel more confidence in the kind of decisions that need to sometimes be made that are difficult decisions, maybe even in a crisis circumstance, because they understand what the patient's preferences are for care. Probably important to point out that not every patient wants really aggressive treatment all the way to the end of their life. There's all sorts of choices that patients make. And there are also physicians with different ideas about how aggressive to be at the end of life. And it's kind of bringing the two together so that in the end, the patient is receiving the care that is their preference, not the physician's preference, because that in the end is your concern for the patient's satisfaction with care, and their supportive caregivers also see that they're getting the care that their loved one wanted, as opposed to something that may be to them forced on the patient because the doctor thought they should have aggressive treatment, perhaps.
I completely agree. I think one of the aims of a program like a serious illness conversation, or what's termed the serious illness care program, one of the main aims is to achieve goal concordant care. So having an early enough understanding of what that person values from their healthcare, what they want in terms of an end-of-life experience, so that when that time comes, they're receiving the type of care and the experience that they hope for.
And I guess some of the dynamics change too, because, of course, when I began in oncology, the number of treatment options that we had for any particular disease were quite limited. Nowadays, name a cancer and there's a second line, third line, fourth line, sometimes many more lines of therapy, so that the length of life can be extended, but each of those lines of therapy may have particular toxicities that, depending on how fit the patient is at that time, may or may not be a good choice for them in terms of how they feel about their overall treatment plan. And so it would seem, and you can perhaps have a better perspective on it than I, but it seems like the need for these kinds of conversations have become greater because of the fact that our treatments are becoming longer and more choices along the way. Is that true?
I think it is, yeah. I mean, when making decisions around treatment, when choosing a treatment path, we want to think about, how it impacts longevity. We also want to think about how it impacts quality of life. And then for this individual in front of us, what do they value the most, and how do we strike a balance? And so having had some serious illness communication along the way where we've learned what's really important to this person's quality of life, or what are their goals, what are the milestones that they're aiming to reach in terms of their longevity, I think it helps us make patient-centered or values-based decisions around the actual treatments. So, again, these are not conversations that should be reserved to the end of life when treatment options are no longer possible or perhaps have run out. These are best timed early on in the course of illness so that it can be woven in with the decisions around treatment.
Well, maybe just speak a little more about who should have one of these conversations. I would take it like patients who have early stage breast cancer, as an example, would not be candidates for these kinds of conversations because the probability of longevity is great. Recurrence risk is relatively low. Is it just those patients where you have that, maybe the answer to the surprise question is no, and you would start with them? And that might be at the first consult when you receive someone, say, with metastatic colon cancer that's very widespread and their performance status isn't very good. Would that be an example of when you might start sort of right at the initial consultation?
So traditionally, it has been used as the surprise question. Would you be surprised if this person could die of their cancer illness or their other serious illness within the next year? And if the answer is no, I would not be surprised, then that's a potential candidate to have a serious illness conversation. That can be tricky to apply in the real world. Some people find that it's, depending on the disease, the prognosis is very hard to estimate with that accuracy, and so they're perhaps a little bit worried about introducing it too soon. Or depending on the scope of someone's practice, physician's practice, it could be largely people with short prognoses, and so it may become difficult to take this approach with almost every patient in their practice. So the surprise question is a starting point, but it has its limitations. So we have done some work at the Juravinski Cancer Centre to try to help tailor what I call triggers based on either the diagnosis or the sequence of treatments that has happened or the types of complications that have happened from the cancer illness itself. We've developed a short list of trigger criteria that can help a physician and the healthcare team narrow down on when are these conversations going to be most high yield. So hopefully we can help choose the right individuals. And then it's the question of timing. So yes, there are people who come to their first consultation at the cancer center and they're already very sick from a very serious cancer. And sometimes there are information needs that we need to get into right away. Often there's only so much that somebody can absorb in one conversation. And so we do have to break it into multiple conversations, perhaps across multiple visits. Maybe at the first visit, focusing on just understanding what is the diagnosis and getting to know each other a little bit and developing that rapport. And then at a follow-up visit, getting a little bit more in-depth in terms of perhaps the prognosis or exploring what that person values most from their healthcare. I would say it's probably not going to happen at the first visit with a healthcare team, but hopefully it can happen early in the course of that serious illness.
So in the example I gave you, being a GI oncologist of metastatic colorectal cancer, you wouldn't do that at the first visit because you don't know what treatments the person might be a candidate for, how they might work. And actually, there might be a series of treatments because the management of colorectal cancer has improved quite substantially. So they might live more than the year and do quite well. So you don't know at that particular point in time. You know that it's a significant illness and they're going to need treatment to hopefully respond and improve and have better quality of life and longevity. But it's not the wrong time to have that more serious in depth. So it's more of a get to know you and develop a sense of what their values are and their family and the building trust relationships. So,
yeah.
But it's still got to be difficult in busy cancer clinics. I haven't worked in one for a while, but when I did, it was busy enough, and I hear that it's always got worse. So it must be challenging because there's still got a waiting room full of people and nurses hanging outside the clinic room door with a list of things of callbacks and orders you need to do, et cetera, et cetera. So how do we manage to even fit these conversations in?
Mm-hmm. I think it's a shared effort. You mentioned the nurses that we work very closely with, and there's a lot of support that and nurses can offer, primary oncology nurses, social workers. Everyone in the healthcare team has some stake in supporting a patient in this way. But in terms of perhaps carving out the time to have a more formalized or structured conversation around this, we might plan for it in order to have a little bit more control over the schedule on that date. So, typically it will be booked for a chunk of time, often roughly half an hour. We'll prepare for it in advance. We'll introduce what is a serious illness conversation. We'll share some materials with the patient and their family at the visit prior, some questions that maybe they want to reflect on and start to talk about before they come back to their next assessment. And then at that next assessment, it's booked into a dedicated slot that perhaps won't interfere too much with the flow of other patient care.
So it sounds like we're getting into the serious illness care program.
Yes.
So maybe this is a good time to take a brief break and then come back and focus on what the elements of the program are.
We'd like to take a moment to thank our generous supporters, the Hutton Family Fund and Banco Creative Studio, who make the Cancer Assist podcast possible. The Cancer Assistance Program is as busy as ever, providing essential support to patients and their families. We remain committed to providing free services for patients in our community, including transportation and equipment loans, personal care and comfort items, parking, and practical education. These services are made possible by the generosity of our donors through one-time gifts, monthly donations, third-party fundraising, corporate sponsorships, and volunteer opportunities. Visit cancerassist.ca to see how you can make a difference in the lives of cancer patients and their families.
We're back talking to Dr. Oren Levine about serious illness conversations and communication and a program to support that. And maybe a bit of clarity that this is the intent of the program is to bring all oncologists and other caregivers in the cancer center along in their abilities to provide more in-depth conversations that assess the values of the patients, what their goals are, and to do this over the course of their illness, particularly as it becomes more serious. And we've defined serious as potentially dying within a year. So right. I got that right?
You do, yes.
Great. So we were going to talk about the program now because it's not about one specialist coming to do these conversations. It's about all oncologists really developing the skills to be able to do it with comfort. And you mentioned that many physicians feel uncomfortable with these conversations. Right. They don't quite know how to introduce them and fear that they might do harm to the patient, upset the patient, make them more anxious, talking about what's in store in the course of the next few months for them. So how do we overcome that, and how do we train them to become comfortable with having these conversations?
Right. Yeah. And that's where I think the serious illness care program comes in, which is really a formalized approach to quality improvement. So for a healthcare institution like the Juravinski Cancer Centre where I work, trying to ingrain this in the culture of that institution and how all the healthcare teams work day to day. And before I describe the components of the program, I guess I do want to emphasize again that serious illness communication or a serious illness conversation is not synonymous with an end-of-life conversation or with palliative care. Palliative care practitioners can certainly play a really important part in this, but this is good communication about what's important, even when someone may not feel that they're at the end of life. How do we help them get the experience that they want over the course of their illness? Again, I'll mention that a serious illness conversation is one that focuses more on values and goals. It can be a structured conversation, and it de-emphasizes decisions, treatments, code status. It may lead to that, but it's not the goal to make decisions in the context of this conversation. Ideally, as we've spoken about, it occurs early or earlier in the trajectory of a serious cancer illness or other serious illness. And it ends up creating a foundation of shared understanding that supports those difficult decisions in the future or over time. Just the process of having this conversation between a person who's sick and their healthcare team, it is therapeutic to foster that connection so the person can feel heard and understood and that their values will be respected. And we want all healthcare providers to have the skills to communicate this way. So now I'll get to the serious illness care program and how do we implement this in a systematic way. So, I'll thank and give credit to the team at Ariadne Labs, which is an organization associated with the Dana-Farber Cancer Institute and Harvard, where this program was developed. I'll specifically name Susan Block, Rochelle Bernacki, Atul Gawanda, providers in cancer care and palliative care who put this together and did the research that supports its value in clinical practice. The program involves a number of elements. At the center is the Serious Illness Conversation Guide. So it's actually a one-page script. There's a series of 7 steps with some specific questions to ask and some patient-tested language. So what do I mean by that? If asking what's important to someone in terms of their goals or their fears, there are phrases that have been vetted with real patients, real people facing serious illness to make sure that these words are understood the way we want them to be understood. So it's a very valuable tool for clinicians to be able to communicate in a way that gets the message across the way it's intended. So we have this communication guide, and then we have education around using that guide. So healthcare providers will take a workshop that's historically been in person, but of course in recent years has transitioned to virtual. So now there are options to do it in person or virtual. And it's usually a half day. It's led by trained facilitators. Those facilitators have taken a full day workshop in order to be able to lead and teach the session. But it's orienting people in the healthcare teams to why this is important, what's the science behind it, and how do we use this communication guide really effectively. The next element of the program is supporting system change within an institution. So putting the resources into place to make this a standard across the board, not just a one-off where maybe one doctor likes to do this and another doctor doesn't, but we want to support and promote these conversations happening with all the doctors and all of their patients who are facing serious illness. That might mean that there's changes in the way that appointments are booked, that there's changes in the way that the documentation happens after that encounter, and the doctor is noting what's happened in the medical record, there can be a structured way that's shared. So all of these components make up the serious illness care program, and that's something that we've tried to adopt throughout our cancer program at the Juravinski.
So I guess the logical follow-on question is, how successful have you been in adoption? Because I can imagine, as in the introduction of any program, you have early adopters, enthusiastic people who immediately see the value and want to be engaged, and you have the large group that will come along, and then you have some laggards who resist and drag their feet. And I can imagine that might be the reaction to this program, and maybe that's what you've seen. How has it gone as you've introduced it?
Yeah, very fair question. And I mean, going into the project and being the physician lead for the project, I didn't envision that I was going to change the way every single encounter happened.
So you were realistic.
I went in, I think, with realistic expectations, but my hope was that in implementing this program, in providing training to all of our healthcare providers, that we might start to sow seeds of this across the cancer program, and that over time those seeds will take root, and we'll see that this really becomes embedded in our culture. You're right that there are early adopters, and so we did this in waves. So we organize ourselves according to the diagnoses that we treat. We call it disease site teams, and so we approached a few at a time, and we provided the resources and the training incrementally until we'd trained everyone in the cancer program, which we did. Almost 200 individuals went through the training, not just physicians, but our nursing team, social workers, and other key healthcare providers. And we tried to monitor the experience through surveys to the healthcare providers, surveys to the patients when possible, and monitoring some of our metrics in terms of how often were these conversations happening in the clinic, how well were they documented. So we could see some clues that this was happening, at least some early adopters, some very positive feedback from both healthcare providers and patients. I'll acknowledge that there's limitations in what we can measure, and that has to do with our IT system, and it's a process in evolution that we hope to reach a point where we can really reliably capture when these conversations happen and continue to promote, encourage, educate. We're not there yet, but we're making slow progress.
What's some of the feedback been from patients and also from the clinicians themselves?
So interestingly, it really echoes what comes out of the actual science or the clinical trial in which this program was tested. We hear from the clinicians that they feel less worry and anxiety in approaching this topic with their patients when they use the resources from this program.
And that was certainly one of the biggest barriers to having the conversations in the first place. So
right.
That's a step in the right direction.
Agreed, yeah. And in feeling less anxiety and perhaps feeling a bit more confident that maybe they're doing this more successfully, they do get more satisfaction from their professional role, which is really, really important. I think healthcare providers are really busy. There are a lot of stresses on healthcare providers. We do see a lot of burnout. We see people finding that they don't have enough resilience to continue in this work. And that's a major problem. So if we can support them in overcoming one of the sources of anxieties in their professional roles, then I think we're helping in a meaningful way. From the patient perspective, we heard that the limited number of people who responded to surveys, again, it's not necessarily representative of all. This is just the data that we were able to capture. Those who responded felt that the conversations that were had were worthwhile, and helped them feel more connected with their healthcare team, helped them feel heard.
Well, those are positives. Has it helped physicians in their decision making at sort of crisis points? When patients get very ill, maybe it's an ICU admission or not, or has that knowledge of the conversations helped their decision-making arrive at the thing that the patient would have wanted? Because maybe the patient's not in a position to even communicate their wishes at a certain point, but you're making a judgment based on your knowledge of the patient, perhaps supported by conversations with the family. These conversations, maybe the program hasn't been in place long enough to really evaluate that, but is there any sense that better decisions are being made?
I'll speak to my experience. I don't know that I can say across the program we've been able to measure that, but one of the goals is that these conversations are had upstream earlier on, and clearly documented, so that if a crisis happens, expected or unexpected, that everyone in the healthcare team has the opportunity to be in the loop, have that critical information, and make decisions in the moment that are based on what we know about this person's values, and perhaps at a time where they can't clearly communicate it themselves. So we need the healthcare team in the loop. We need the family in the loop as well. So one key is being able to document this in a very clear way that's easily retrievable from the medical record, which is a complicated space that houses a lot of information. So we need it at our fingertips, and we're absolutely working on that, actually, with changes happening in the coming days. I'm excited to share with any healthcare colleagues that are listening. It's actually going to get even easier to document this and retrieve the information for those critical decisions. But briefly, I'll just touch on my own experience when I've had these conversations, and I've been able to have the conversations upstream or before a crisis happens. I think it actually helps avoid the crisis. If we hear from somebody that in the event of deterioration of their health because the cancer is getting worse, and when it's time to prepare for end-of-life care, and if I've heard very clearly that someone has a fear of dying in the hospital, which some people do fear, and if I hear very clearly that somebody wants hospice-based care, I need to make sure that I'm making the appropriate referrals before it's too late.
In a timely fashion, yeah.
Yeah, and if I've done those referrals in a timely fashion, then often, we can have comfortable transition from active cancer treatment to end-of-life care in the environment that the individual prefers, without necessarily that person having to land in the hospital in a moment of crisis to then change their approach to care.
Right. Well, that was a definite benefit. You referenced the evidence coming out of the trial. Maybe it would be good for our listeners just to hear what the evidence is that supports the work you're doing.
Mm-hmm. So the seminal evidence comes from what's called a cluster randomized trial. This was done at Dana-Farber Cancer Institute associated with Harvard. They took healthcare providers in that cancer institute, and it was the healthcare providers that were randomly assigned to either take this training and use this approach, the serious illness care program, use this approach to their clinical work, versus those who did not take the training and just continued to provide their standard usual care. They looked at a whole bunch of outcomes in this clinical trial, but the ones that stand out as having been impacted in a very good way, when the doctors had taken the training and used the serious illness care program, there was a meaningful difference in the rates of moderate depression and anxiety, and among patients, I should say, and they particularly the benefit in reducing moderate anxiety that was sustained for 6 months, even beyond having had that initial conversation. Mm-hmm. So a very meaningful impact in quality of life. We saw that the quality of documentation of patients' goals and wishes was better in the medical record, that the information was more easy to access, that more high-quality conversations were happening when this systematic approach was used.
I gather, too, participants actually had a better understanding of their future health care as well, that was improved, and felt they had an increased sense of control, which I think patients often feel total loss of control with a diagnosis and ending up in an institution where it just seems things are done to you rather than for you at times. So those are important gains too. I think one of the thoughts was with this kind of intervention, it might make a difference to resource utilization, particularly towards the end of life. I don't think that's been shown to be the case, but you can certainly imagine in some situations that maybe really aggressive interventions might be avoided, which aggressive interventions today, you can substitute the word expensive for aggressive, and in a stressed healthcare system, that would be a benefit if it occurred, but maybe the evidence isn't there to really show that that's the case. Now, you've had the experience of implementing it, and what have been the main barriers you've seen at the Juravinski, because they'd be relevant, I'm sure, to cancer centers across the province and indeed across the country.
If it's okay, I might talk about facilitators first.
Okay, well, let's talk about the positives before the negatives.
What allowed us to look at implementing this across our cancer program, I think that having support from senior administration was critical.
It's always important to have leadership support, yeah.
Leadership support, having clinical champions. In our program, I worked with a really passionate and engaged team. I worked with a bioethicist, clinical educators. We had champions from our nursing team. So thinking about the different stakeholders, this is not just about physicians, and having a team to lead the project. I think that allowed us to see it through to completion. What barriers? We worked through a number of changes. This happened during the COVID pandemic. We had to pivot to virtual education. We went through a transition in the electronic medical record, which is, an enormous amount of upheaval in everything to do with healthcare when that happens. So I think the lesson there is that healthcare is always changing, and any program to be successful has to adapt. Exactly. Yeah. And perhaps where we've had the biggest struggles is when we're not ready to adapt to the way that the healthcare system is changing.
Yeah. And speaking of the EMR, I know it's been challenging, but one of the things in my reading, and I guess with future uses of AI, that it would be able to help identify patients for these conversations by identifying various factors in the clinical record and triggering a notation in the EMR that the clinician should consider one of these conversations. Are you thinking about that in the future?
So that's a great question. There is some science behind that, leveraging the data that's already there in the electronic record to see if we can more successfully identify patients at the right time to have this type of conversation. I think we have the technology now in place to look at doing that. We're not in conversation around that at the Juravinski, and I think it perhaps it has to do with what resources we have committed to our IT system. There are lots of centers who don't have the technology in place and wouldn't be able to turn to AI for that purpose. And so whether or not we're using AI, I think there are ways to still implement successfully a program like this.
Okay. Yeah. And so this has been going on at the Juravinski, and it came out of Dana-Farber. What's its sort of spread like, and what initiatives may be underway to influence other cancer centers here in Ontario or across our country to adopt this approach? Because to me, it's really a caring, sensitive approach to dealing with people with a very serious illness, and almost shake your head and say, why wasn't this done decades ago? But it's good that it's being addressed today. But where are we in further implementation and spread?
Yeah, I mean, we were able to implement this specific program at the Juravinski because of support provided from Ontario Health, Cancer Care Ontario. All cancer centers across the province were encouraged, actually required, to choose an initiative to commit to, and we chose a serious illness care program. Other centers would have chosen other initiatives, but with the goal in mind of facilitating goals of care conversations. That term is similar to serious illness conversations. So it came from top down, and there was organizational support. At the same time, there's a lot of spread of this program just through what I'll call grassroots initiatives. When people hear what we've done at the Juravinski from other centers across the country, big centers, small centers, someone might take interest and reach out and say, hey, what was your experience? I'm interested in doing this at my center. What are some of the lessons learned? So that type of, word of mouth has helped spread this program to lots of different centers.
Well, maybe following this podcast, you'll be getting calls from farther afield. You never know.
Never know.
If that occurred, I guess that would be a good thing, although the workload may not be welcomed that much. But it is a great initiative. Are there any last thoughts you would like to leave our listening audience with? Things that we maybe didn't touch on, I didn't have a question about, but ideas you'd like to get out to the listeners?
Yeah, I think maybe the last thing that I want to share is I hope that a lot of individuals are listening from the community, maybe individuals who have illness, maybe even serious illness. And I want to encourage those listeners not to be afraid of a conversation like this. Again, this is not an end-of-life conversation. This is a conversation to help you connect better with your healthcare team, help them learn from you what is most important. And although the program, the way it exists at the moment, is largely physician-driven or healthcare team-driven, I encourage all patients, perhaps who've heard about this program, to ask, can we have a conversation like this? Use this as an opportunity to make sure that you are heard. Use this as an opportunity to fill the gaps of information that you need to understand your health and plan for the future. So please don't be afraid of a conversation like this. And then the flip side of that is to the physicians or healthcare personnel who are listening, please don't be afraid of a conversation like this. Taking this approach, doing it systematically, being organized, it tends to help people feel less anxious, more confident, and more satisfied. So this will make a meaningful difference in your practice.
That's a great final message. I can't do better than that as a wrap-up. So I'll just thank you very, very much. You're obviously a very caring physician, and I'm so glad you're leading this initiative in our community. And your message to both patients and to providers, I think, is one I hope they take to heart, because I think it would just improve further the high quality of care that's delivered at the Juravinski Cancer Centre. And I just want to thank you for your time and the effort you're putting into launch a program, maintain a program, do research about it, and it can only lead to better things and more satisfaction for patients who are on this journey with cancer. So, Oren, I want to thank you very much for participating in this podcast today.
It's a pleasure. Thank you for having me.
Thank you for listening to the Cancer Assist podcast. Find more episodes, resources, and information at cancerassist.ca, or follow the Cancer Assistance Program on Facebook, Twitter, and Instagram. Thanks for listening.